The standard treatment for limited stage small cell lung cancer is concurrent chemo and radiotherapy. And we know that some patients are cured. The proportion varies, but it's between 25-30% in most studies. So that means the treatment is very good for some patients, but we evidently need more effective treatment. But there hasn't been much progress the last 20 years, which can also be seen in population-based studies, that the survival for small cell lung cancer has remained more or less unchanged. While for non-small cell lung cancer, there's been quite a good improvement in the same period. So we hypothesized that increasing the dose of the thoracic radiotherapy might improve survival. I think the mechanism would be that we increase the local control, which is one of the causes for recurrent disease. This is a Scandinavian trial. We collaborated with colleagues in Sweden, Denmark, and of course in Norway. And we enrolled 160 patients who received study treatment per protocol. There was quite a good balance between the treatment arms, both with respect to the baseline characteristics, but also concerning treatment completion. The primary endpoint was 2-year survival. We chose that endpoint because the median survival time is usually 2 years or less in trials of limited stage small cell lung cancer. And to our surprise, we found a substantial improvement. 75% of patients were alive in the high dose arm, while it was only 51% in the control arm. The control arm performed more or less as in the previous trial and as expected. But as I said, the improvement was quite much higher than we expected. The survival data are not completely mature, but there also seems to be a statistically significant improvement in the median overall survival from 24 months in the control arm to 37.2 months in the experimental high dose arm. So these data we presented at ASCO. Now we have analyzed the PROs. We know that the objectively assessed toxicity was similar in both arms. The most important toxicity is probably esophagitis, 18.4% in the control arm and 19% in the high dose arm. The patients reported quality of life on the EORTC QLQ-C30 and the lung cancer module LC13. And they reported at baseline inclusion before the start of thoracic radiotherapy, when they completed the thoracic radiotherapy, after completing the prophylactic cranial irradiation, and then at follow-up every 10 weeks until the end of the first year. We didn't find any difference in the maximum dysphagia, which is one of the primary quality of life endpoints. Of course, there was dysphagia in quite many patients, but the mean score increased from approximately 10 in both arms till to 45-50 in the time period after completion of the thoracic radiotherapy. And the difference in the mean score was 6 or 7, which is quite a small difference. I think in most studies it's well accepted that a difference of 10 points in mean score is probably the minimum difference that is clinically relevant for patients. And at follow-up on week 22, all patients reported scores that was more or less similar to baseline. The only difference was that the patients on the high dose arm, it seemed that it took them a bit longer to recover from the dysphagia, which can be seen on assessment time points 4 and 5, where there's a difference of more than 10 points. But our interpretation would be that considering the large survival benefit, it's probably acceptable for patients to have a slightly longer time period with dysphagia, as long as they recover in a few weeks after the patients on the control arm had recovered. The other primary quality of life endpoints were dyspnea. There was actually no difference, neither between the treatment arms, but also the difference during the study period was very small. And the same applied for physical function and the global quality of life. Our conclusion is that these PROs support the reports by the physicians that there's actually not much difference in toxicity between the treatment arms. As I said, the patient on the high dose arm took a little bit longer to recover, but at week 22, they were also back to their baseline values for the most important toxicity, dysphagia. I think that more or less summarizes the report here at the ESMO meeting.